Multiple medications are required to achieve BP control in clinical trials. So in patients with diabetes, it is not always, single drug is not always working. So different styles, Accomplish, Alhart, Hot, Accord, all of them, as you can see, that they are showing that more than one drug is always required to control, to optimize the blood pressure. So single drug, very unlikely that it is going to work in patients with diabetes and having hypertension. So you will have to go for more than one molecule. Again, a revision, patient found to have an elevated blood pressure of more than 140 by 90 mm of Hg should have a blood pressure confirmed using multiple readings. So you will satisfy your diagnosis, you will confirm your diagnosis by giving the environment to the patient, applying proper measurement technique of the blood pressure. After that, all hypertensive patients with diabetes should have home blood pressure monitored to identify white coat hypertension. So white coat hypertension should be excluded in your patient. Orthostatic measurement of the blood pressure should be performed during initial evaluation of the hypertension and periodically at follow-up to rule out the autonomic neuropathy in patients with diabetes and the side effects of the medication, which is reflected in the form of orthostatic hypertension. So a patient with 10-year ASCVD risk more than 15%, less than 130 by 80 mm of Hg should be your target goal of blood pressure in these patients, while patients with 10-year ASCVD risk less than 15%, a blood pressure 140 by 90 is acceptable in these patients. These are the ADA recommendations for control of blood pressure. So nothing is with side effects. I will share with you another small study which was done in 1979 by Stewart. He found it out that he chased the patient for 6 years with antihypertensive medications, and he found out that the coronary artery disease, or MI, was increased by 5% those who are having intensively controlled blood pressure. So this theory is floating there, but it didn't get recognition, because when it was again peeped into, it was found that it was not actually the lower blood pressure which caused these events, rather there were other factors involved. But data is there, you can check it, that one of the studies shows that intensive control of the blood pressure lead to increased MI in patients with diabetes. Finally, I'm take-home message, just 1-2 minutes. Patients with diabetes and hypertension should be treated to a systolic blood pressure and diastolic blood pressure of less than 140 by 90 in general population. Lower targets such as 130 by 80 may be appropriate in younger patients and those with microvascular complication. Early drug therapy for patients with confirmed BP more than 140 by 90 mm of Hg, as well as lifestyle therapy, should be initiated. Initial agent of people living with diabetes and hypertension should be ACE inhibitors or ARB for the reasons which my colleagues have already discussed in the nephrology section. Individualization of treatment taking into consideration patient characteristic, preferences, potential side effects should be beared in mind while treating patients for hypertension. Timely titration of the therapy to achieve a BP goal. This is what is called the therapeutic inertia should be in your mind, that whether your drug is working or not, so you should repeatedly check the blood pressure of the patient. One should use antihypertensive agents that do not worsen pre-existing metabolic condition. So you should be choosy with your drugs, looking at the condition of the patient. Finally, I will close my discussion with the saying of William Osler: the good physician treats the disease, the great physician treats the patient who has the disease. Korvadan, this is what we say for thank you in our Quetta terminology. Thank you very much for patience listening.
Thank you, sir, for a very nice talk, particularly on a very important topic of management of hypertension in diabetic patient. Now I welcome our Vice Chancellor, Professor Dr. Zafar Ali Chaudhry. I think he is in the hall or not. There will be the lucky draw after this presentation, and the winner will get the laptop. And remember, the winner must be present in the hall at the time of lucky draw. Otherwise, we will cancel the lucky draw. नहीं, हमने नागरा साहब को वैसे ही दे देना सर के लिए लैपटॉप हाजिर है. No, our next speaker is from Malaysia. He is an honorary professor of medicine and senior consultant endocrinologist in the University Sans Malaysia. He was formerly the assistant vice chancellor and director of campus and also director of hospital at the same university in the Kelantan, Malaysia. He is member Royal College of Physicians UK and also has his master degree of medical science. Now I request our worthy guest Professor Dr. Mufaze Muhammad from Malaysia for his a very beneficial talk on expanding horizon for holistic type 2 management with Daglodec aspart. Professor Dr. Mufaze Muhammad. Sir, please.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and good morning, ladies and gentlemen. First of all, I'd like to thank the organizer for having me in this conference. So I'll be talking a bit more on the newer insulin IDAC apps and the ARISE study which were involved, which is a real-world study for diabetes mellitus. Can I get my slides on, please? Okay. So this will be the agenda for my talk, basically to talk about why we treat diabetes mainly and the standard of care as far as diabetes management is concerned, especially with the use of injectables. The importance of total glycemic control, it means not only A1C, but also the fasting and the postprandial, and the new insulin, the insulin insulin degludec aspart, or in short, ARBs, and the clinical guidance for the use of ARBs in diabetes management, and summary and takeaway from our ARISE study. Okay. These are my disclosures for this talk. First of all, I think I'm sure many of you are aware that the reason why we treat diabetes is really to prevent complications. And the two complications that we are worried about in people with diabetes are the acute complications due to severe hyperglycemia, which is hyperosmolar hyperglycemic shock state, and diabetic ketoacidosis due to very high levels of blood glucose. And the other, of course, is the long-term complications such as macrovascular complication, microvascularization complications. And we know that good glycemic control can reduce the risk of these complications. And we know that the main cause of mortality in patients is actually atherosclerotic cardiovascular disease, heart attacks and stroke. 2/3 of our our diabetic patients died because of heart attacks and stroke. Hence the importance of treating the other factors as well, apart from glucose, to prevent heart attacks and stroke. And also a concern about the chronic end-stage renal failure, where many of our patients who have end-stage renal failure, the main cause of that is actually diabetes mellitus. Now I'm sure we're all very familiar with the macrovascular complications of diabetes, talking about the microvascular complication all the way from cognitive impairment, retinopathy, neuropathy, nephropathy, and the diabetic foot. And the microvascular complications such as cerebrovascular disease, atherosclerotic cardiovascular disease, heart failure, and the other complications which are also becoming coming up in the forefront now, such as dental diseases, infectious disease, and also the non-alcoholic fatty liver disease, or now termed as metabolic associated fatty liver disease. So these are the so-called chronic complications of diabetes. Okay. So what is important for reducing long-term complications? I think the previous speaker talked about blood pressure control, which is B. Okay. Is the ABC. Some of you are familiar with A, stands for A1C, which means glycemia. And we know that high blood glucose becomes toxic, especially to the blood vessels, and cause endothelial dysfunction. B for blood pressure causes damage to the heart and blood vessels, again causing vascular dysfunction and complications. And C is for cholesterol. And we know that high cholesterol causes atheroma, narrowing of the arteries, and thrombosis, leading to heart attack, strokes, and peripheral vascular disease. Okay? And heart attacks and strokes, as I mentioned, are the most common causes of death in people with type 2 diabetes. Okay? And now, coming back, so my focus is on the A1C, okay, which is the glycemic control. How well are we in getting our patients to target? From this study, it's shown that generally worldwide, many countries actually fail to get the majority of their people with diabetes to target. Okay? Talking about type 1 diabetes, even in the US, the main A1C is 7.5. If you talk about the controlled diabetes having an A1C of less than 7, and you can see that many of these countries have a mean A1C of more than 7%, okay? Even in the developed countries. And type 2 diabetes also is worse still. Okay? And the US, for instance, the mean A1C is 8%. Okay? And coming to the Asian, China, for instance, 7.6%, Korea, 8%. So in general, many patients the majority of patients with type 2 diabetes worldwide do not achieve target. So we have to find out and reasons why many of these people are not achieving targets. Okay? And one of the reasons that we found, that the studies have found, that it's so-called treatment inertia. Treatment inertia means treatment is not intensified in a timely manner to achieve adequate glycemic control. Despite having not well controlled blood glucose, A1C, people are not being treated or intensified in the treatment. Okay? In this study, for instance, in people with type 2 diabetes and A1C of more than 7%, okay, many of these patients remain on oral anti-diabetic agent despite having an A1C of more than 7%. And 42% of these patients had an A1C of more than 9% before they start insulin. Okay? And the median time to intensification with insulin is about 7.2 years since the start. So which means that many of these patients are living in a hyperglycemic state for a long duration. And we know that this is driving the complications of type 2 diabetes, so-called the bad legacy effect of chronic hyperglycemia. Okay? And one of the issues that people have found is the so-called the treat to failure type of strategy that many of us are using. Okay? First, what treat to failure means that upon diagnosis of diabetes, started on oral one monotherapy, okay? And of course the patients normally respond, but over time, with the progressive failure of beta cells, A1C to creep up, and when the A1C comes to 8.4%, a second oral anti-diabetic agent is started, okay? And then the patient responded, and again after a while it goes up again, and by the time the third OAD is added, A1C is 8.8%. And it comes down, and then again went up, and by the time insulin is initiated, the A1C is about 9%. So showing that patients are remaining in the chronic hyperglycemic state for a long duration. Yeah? So the current strategy in terms of diabetes treatment is treat to target. Treat to target means you have to try to attain target of less than 7% as soon as possible, and try to maintain the patient at less than 7% for as long as possible, which means that we may have to add dual combination, triple combination, and even insulin at an earlier stage. And studies have shown that it can be achieved to get patients to target and remain at target for a long duration. Okay, so this is called treatment to target approach strategy in terms of treating diabetes mellitus. Okay? So coming back to the algorithm for intensifying to injectable therapies. Okay? So when do we start injectable therapies in people with type 2 diabetes? Obviously, when they fail to achieve target on oral anti-diabetic agent. And the first injectable recommended by the American Diabetes Association, and even in other guidelines, I say even our own Malaysian CPG clinical practice guideline, we do recommend that the first injectable is GLP-1 receptor agonist, and of course the new one, the duo incretin agonist. Okay? And reason being because the majority studies have shown that GLP-1 receptor agonist is more superior to insulin in getting patients to target, in terms of A1C target. And the reason being because many of our type 2 diabetic patients have insulin resistance, they're obese. Okay? And GLP-1 receptor agonist, by getting patients to lose weight, you can get the patients to have better glucose control. But insulin, it can be the first line of treatment in patients who have symptoms and signs of insulin deficiency. So what are the symptoms and signs of insulin deficiency? Are that when the patient is quite symptomatic as far as hyperglycemia is concerned, i.e. they have thirst, polyuria, or they have an A1C of more than 10%, or a fasting glucose of more than 300 milligram per deciliter. Okay? So these are patients with symptoms of severe insulin insufficiency, where the treatment injectable will probably be insulin, because GLP-1 receptor agonist is not insulin. Yeah? It requires functioning beta cells to work. So in patients who have insulin deficiency or insufficiency, putting them on GLP-1 receptor agonist will probably not work for them. They have to be started on insulin. Yeah? And so patients, after being started on GLP-1 receptor agonist and the A1C is still above target, then you add insulin. And the recommended insulin to be added is basal insulin. Okay? And then from then on, escalate, intensify the insulin therapy, adding, if they were on human basal insulin, which is NPH, normally given once a day, can be given twice a day. And then to intensify the basal insulin therapy to optimize the dose. Right? And if that fails, okay, they suggest to add prandial insulin on top of the basal insulin. And prandial insulin can be given as once basal plus 1, i.e. 1 prandial insulin at the biggest meal. Okay? And later on, if it's not controlled, with basal plus 2 prandial insulins at 2 meals plus the basal, and later on to the full basal bolus, 3 prandial plus a basal. Okay? Or the other alternative, they say, is you can go on the premixed insulin. Premixed insulin contains both the prandial insulin and the basal insulin in one pen. Okay, so we are giving prandial and insulin, basal insulin at the same time. Okay. Now, so what are the realities in Asian populations with type 2 diabetes? Okay. The realities is that in Asians, we have a very high carbohydrate consumptions. So which means our problem is basically a postprandial and not a basal. Okay? Which means that because basal insulin affects mainly the fasting insulin, which is the hepatic glucose production. Whereas if you have high carbohydrate meals, then our problem is mainly postprandial. And looking at the figures, just focusing on Pakistan, for instance, but more than 70% of your diet comes from carbohydrate, similar to Malaysian as well, 60-70%, whereas the recommendation for carbohydrate is normally about 50 to 55%. Okay? So very high carbohydrate consumption in the Asian countries. Okay? Of course, I was given this photo showing the typical sort of Pakistani meal loaded with carbohydrate. Okay, you have very nice biryani. Okay, I like your biryani, but of course have to take in moderation. Yeah? And high carbohydrate meals causes very high postprandial blood glucose, and this stimulates the beta cells to overproduce insulin and can give rise to insulin hyperinsulinemia, can give rise to high insulin resistance. Okay, so you are making the issues actually worse by having high carbohydrate meals. Yeah? And the issue with basal insulin, as I mentioned, is that it mainly affects the fasting state. Okay? It sort of prevents the liver from producing glucose in the fasting state. Okay? So when in the early stage, okay, it tends to work very well when the dosage of insulin, the requirement of insulin is less than 0.3 unit per kg body weight. Okay? But as the requirement of insulin increases, okay, from 0.3 to 0.4, then the sense of the efficacy of glucose lowering or A1C lowering diminishes. Okay? From 0.3, for instance, it can decrease the A1C by 1.1%, 0.3 to 0.4 down to 0.07%, and by 0.4 to 0.5% A1C reduction. And if you were to increase the insulin requirement higher, then the benefit is much less. Okay? So, and studies have shown that when basal insulin is more than 0.5 unit kilogram per day, then the effect is significantly reduced as far as the effect on A1C lowering. And the problem is that by pushing the insulin dose higher, we get the side effects of insulin, which is additional weight increase of 1.8 kilogram was seen when the insulin dose was increased above 0.5 unit per kilogram per day. So suggesting that, and the more weight we gain, the more insulin resistance that the patient becomes, and the worse probably be the glucose control. Okay? So when we talk about total glycemic control, which basically means A1C, okay, we have to remember that A1C comprised of contributed by not only fasting plasma glucose,